Bismillahirrahmanirrahim. Dear student, my lecture is about movement disorder. That is means the main presentation is the development of abnormal involuntary movement. So, movement disorder refer to any clinical syndrome with either excess of the movement or poverty of the movement, unrelated to the weakness. There is no weakness explain this abnormal involuntary movement. Sometimes we called basal ganglia disease. Why? Because in patient with movement disorder, the pathology is due to a lesion in the basal ganglia. And sometimes we call extrapyramidal disease because the basal ganglia is a part of the extrapyramidal system. First, try to revise part of the basal ganglia to help to discuss my lecture. In the basal ganglia, there is a group of nuclei scattered elsewhere in the brain. The most common nuclei is corpus striatum, which subdivided into caudate, putamen, and globus pallidus, thalamus, subthalamic nucleus, and substantia nigra. Lesion in one of these nuclei will produce a certain type of involuntary movement. For example, lesion in the substantia nigra will develop Parkinson's disease. Lesion in the caudate will develop chorea. We put a statement in my lecture. Patients with extrapyramidal diseases present with two major clinical signs and symptoms. First, presence of the involuntary movement, which we'll discuss it later, and change in the tone. All extrapyramidal diseases will increase the tone, and the tone, when increased due to extrapyramidal lesion, is called rigidity, while the tone increased due to pyramidal lesion is called spasticity. So in my lecture, increased tone is called rigidity because it is due to lesion in the extrapyramidal system. All extrapyramidal diseases will increase the tone in the form of rigidity, except chorea, associated with diminution of the tone. In the patient with extrapyramidal, the motor system, the sensory system, the cerebellar system is not affected. So we don't found any change in the muscle power, any change in the sensation, or cerebellar unsteadiness. First, before we start my lecture, try to put a simple classification for extrapyramidal system. We divide the patient into hypokinetic movement disorder and hyperkinetic movement disorder. Hypo means diminish, and kinesia means movement. Patient, the main presentation is diminution of the movement, limitation of the movement, bradykinesia. Under this group, we put Parkinsonism, which is the best example for hypokinetic movement disorder. Hyperkinetic movement disorder, the second group, is associated with the development of one of the abnormal involuntary movement, like tremor, like chorea, hemipalismus, dystonia, acetosis, myoclonus, and tics. And we discuss this involuntary movement later. Hypokinetic dyskinesia. Hypo means diminished. Kinesia means movement. Diminution of the movement. Patient complaining of slowness and poverty of the movement. Under this category, we put a Parkinsonism. Parkinsonism is a clinical syndrome. To diagnose it, it should fulfill the clinical criteria, which is tremor, rigidity, slowness of the movement, and postural instability. There are many types of Parkinson. The most commonest type is idiopathic primary Parkinson disease. The second is secondary Parkinson, secondary to any insult to the brain. The third is what is called Parkinson plus syndrome. What is meant by Parkinson plus syndrome? When we examine the patient, we found involuntary movement, we found increase in the tone in the form of rigidity, and other CNS affection like cerebellar lesion, pyramidal tract lesion, and so on. So it is not a classical Parkinson, it is a typical type of the Parkinson. Secondary to what? Secondary to any insult of the brain. Sometimes patient presented with encephalitis, CNS infection, and the infection involves the basal ganglia, and later on, patient will develop a Parkinsonian feature. So it is called post-encephalitic Parkinson. Atherosclerosis of the brain, ischemia of the brain. It may involve the basal ganglia and the extrapyramidal system. So there is atherosclerotic Parkinson's disease. Sometimes patient come with Parkinsonian manifestation, not a disease, associated with or induced by some drugs like psychotic patient, acute agitated patient. When we receive antipsychotic in higher dosage in potent form, we'll develop Parkinsonian-like picture. Some toxin may induce Parkinson, like carbon monoxide and manganese. So past history in this patient is important to exclude some of the secondary Parkinson. Some of this may be a treatable disease. The next cause of secondary Parkinson is repeated head trauma. And person susceptible to repeated head trauma is a boxer. Boxer may prone to development of the Parkinson. Metabolic disorder, and on the top of metabolic disorder is the Wilson disease, disturbance in the copper metabolism. Wilson disease may present by any type of involuntary movement, dystonia, Parkinsonia-like acidosis, and so on. So it should put in the differential diagnosis of any patient presented with involuntary movement in the younger age. Lastly is the tumor of the basal ganglia, and this is a very rare. We discuss in detail idiopathic Parkinson disease or primary Parkinson disease. Parkinson disease is idiopathic. That means there is no settled etiology. Second, it is one of the neurodegenerative process. Neurodegenerative means gradual progressive degeneration of the neuronal cells. That means the history and the course of the patient is gradual progressive. It is the disease of the old age, around 60s. Male is affected more than female. In rare cases, we found the disease in younger age group or in juvenile age group. So it is called young onset Parkinson or juvenile onset Parkinson. And in this group, we should exclude one of the list of the secondary Parkinson. Pathology. In pathology of Parkinson disease, the main lesion is in the substantia nigra, which is nuclei related to the basal ganglia, as we discussed before. And this nuclei is present in the upper midbrain. This nuclei is pigmented nuclei, take a brownish color. And it is the factory for manufacture of the dopamine in the brain. And dopamine is the main inhibitory in the brain. Pathology involves the substantia nigra and the other basal nuclei, but mainly the substantia nigra. In this disease, there is degeneration of the cell because it is a neurodegenerative, depigmentation of the cell lost the pigment, and there is aggregation of the intracellular alpha-synuclein protein, which is called alpha-synuclein protein, to form what is called Lewy body. Lewy body is diagnostic for idiopathic Parkinson disease. When we not found the Lewy body in the examination of brain biopsy, that means the Parkinson is not idiopathic. It may be one of the secondary Parkinson. This is the figure for substantia nigra in the top of the normal personnel, bulky and brownish in color, and in the bottom, the substantia nigra of patient with Parkinson is atrophied and depigmented. This is the Lewy body in the brain biopsy, and it is diagnostic hallmark for diagnosis of idiopathic Parkinson. Etiology. We called idiopathic, no settled etiology. The etiology not clear up till now. It is the combination of genetic and environmental. In the last 10 to 15 years, we discover some patient with a positive family history of the disease. That means the disease has some underlying genetic etiology. What is the pathogenesis? And this is important to line the treatment. Pathogenesis, we look to the caudate nucleus. Caudate nucleus between two arms. Striatonigral pathway, the main neurotransmitter is dopamine, and this is an inhibitory. Thalamostriatal pathway, and this is controlled by neurotransmitter acetylcholine, which is excitatory. So the caudate is imbalanced between the main inhibitory dopamine come from the substantia nigra, and the main inhibitory acetylcholine come from the thalamus. So the caudate is in a state of balance. In patient with Parkinson, there is degeneration and depigmentation of the substantia nigra. The amount of dopamine released will diminish. The inhibitory will diminish. So the caudate became imbalanced between the main inhibitory dopamine and the main excitatory acetylcholine. This is the underlying pathogenesis for the development of Parkinsonism, and it's important in the line of treatment. Try to correct this balance. Try to elevate the dopamine and decrease the acetylcholine. Clinical presentation, and this is very important when we diagnose a patient with idiopathic Parkinson. Patient with idiopathic Parkinson complaining of 4 major cardinal signs: tremor, rigidity, bradykinesia, and loss of postural instability. The first clinical sign is tremor. Tremor is regular rhythmic movement at the joint level due to contraction of group of muscle and its antagonist, flexion and extension. In the hand, start at the metacarpopharyngeal joint, then extend to involve the interpharyngeal, then extend to involve the wrist, and the thumb presented with bell rolling phenomenon, like this. The second location is around the ankle, flexion and extension in the lower limb. The third location is in the head, flexion, extension, what is called head nodding. Yes. The fifth location is opening and closure of the mouth, like this, fish mouth. And lastly, on the tip of the tongue, ask the patient to protrude the tongue and found the tremor on the tip. What are the characteristics of the Parkinsonian tremors? It is the best example for resting tremor. Ask the patient to relax. We found the tremor is present as we discussed before. It is resting tremor. It is coarse, 4 to 7 cycles per second. Any involuntary movement aggravated by emotions or stress. The tremor is decreased by voluntary action. When patient perform voluntary action like hand grip, it will diminish, completely disappear during sleep. The next clinical sign is the rigidity. Rigidity, how to examine rigidity? To examine tone is passive movement around the joint while the patient is relaxing, around the elbow, around the knee, and around the wrist. In patient with Parkinson's disease, the tone is increased. So there is what is called rigidity all over the range of the movement. When try to extend the limb and flex the limb, we found increased tone all over the range of the movement from the start till the end. This is called lead pipe rigidity. And the most classical joint to examine the lead pipe rigidity around the elbow and around the knee. But when we examine the tone around the wrist, in the presence of tremor, the tremor will interrupt the tone. We found what is called cogwheel rigidity. Ask the patient to relax and try to do a full range of movement around the wrist. We found the movement is interrupted, like this. Interrupted movement, cogwheel rigidity. Again, in patient with Parkinson, the tone is increased in the form of rigidity. There are 2 types of rigidity. In the absence of tremor, there is a lead pipe. In the presence of tremor, it is a cogwheel rigidity. Rigidity is responsible for many clinical signs in the patient with Parkinson. First is a masked face, expressionless face. What is the sign lead to this expression face? First, there is loss of wrinkles due to rigidity of the facial muscle. The patient is older age, but it appears younger than his age. There is loss of normal reflex blinking, which gives its face its vitality. There is a staring look and wide palpebral fissure. All these 4 signs together give the impression of masked face. Second, the attitude of the patient. Attitude of the patient is the flexed attitude, like this. All the skeletal muscle is rigid, but the rigidity is more in the anti-gravity muscle. What are the anti-gravity muscle? The neck flexor, flexion of the neck. The biceps, flexion of the elbow. The paravertebral muscle, flexion of the back. The hamstring, flexion of the knee. There is a flexed attitude. And the center of the gravity of the patient in the front, leading to propulsion during walking. And the gait of the patient is the short steppage shuffling gait. Movement. There is normal power because the motor system is not affected, but patient all the time complaining of subjective weakness, easy fatigability, arthralgia due to strain of the rigid muscle on the joint. Articulation is affected. How to examine the articulation? Ask the patient to read Al-Fatiha When the patient we read the Fatiha, we read like this. Bismillah ar-Rahman ar-Rahim, Alhamdulillah Rabbil Alameen, ar-Rahman ar-Rahim, Malik Yawmiddin. There is one tone because the vocal muscle is rigid. The patient unable to change the pitch of the sound. It is called monotonous dysarthria. Also, the pharyngeal muscles and the laryngeal muscle is affected. There is dysphagia. There is difficulty in mastication and deglutition. There is frequent dribbling of the saliva due to difficulty in swallowing and due to hyperactivity of the salivary gland. Glabellar reflex, it is positive in patients with Parkinson. Glabellar reflex is under the control of the facial nerve. How to examine glabellar reflex? Stand beside the patient and tap on the root of the nose. In the normal patient, when we tap on the root of the nose, there is reflexive blinking of the eyelid, 1, 2, 3. Then the reflexive blinking stop in spite of maintenance of the tapping. But in patient with Parkinson, there is no adaptation. There is continuous blinking while the tapping is maintained because adaptation is due to presence of the dopamine. While in patient with Parkinson, the dopamine is deficient, so there is a lack of adaptation. In the upper limb, there is rigidity of the hand muscle. So there is a micrographia, small handwriting. In the lower limb, the gait like this, short steppage, shuffling gait. There is a propulsion. Rarely we found the opposite, the retropulsion. There is loss of associated habitual movement. During walking, there is swinging of the arm. When we stand, we may cross his leg, but the patient is look like a robot, unable to use the body language to express her articulation due to difficult in maneuver due to rigidity of the muscle. The third clinical sign is bradykinesia, slowness of the movement and the loss of associated habitual movement. Later on in the disease, with the progress of the disease, there is postural instability and impaired balance and tendency to fall and may prone the patient for pathological fracture because the patient is older age. Sometimes patients present with neuropsychiatric presentation like sleep disturbance, insomnia, interrupted sleep, depression, anxiety, dementia late in the disease, and it's called subcortical dementia. But when dementia is present with the start and aggressive, it is Parkinson plus this syndrome. Psychosis, hallucination, and delusion may occur as the progress of the disease and may be side effect of the drug with gradual rapid titration of the anti-Parkinsonian treatment. Try to think. Elderly patient is referred to clinic for evaluation of the tremor. So, the main presentation of the patient is tremor. On examination, he has arrested tremor, worse on the right, there is asymmetry, diminished facial expression, decreased arm swinging, loss of the habitual movement, shuffling gait, with short, rapid step. And when we examine the tone, we found a cogwheel rigidity, more on the right. What is the most likely diagnosis? How is idiopathic Parkinson disease patient diagnosed? Either by laboratory investigation, neurological examination, neuroimaging, all of the above. And what are the indications to do laboratory and neuroimaging investigation? Patient with idiopathic Parkinson, when we fulfill the cardinal signs of Parkinson, tremor, rigidity, bradykinesia, loss of postural instability, patient with idiopathic Parkinson without investigation. So the main line for diagnosis is clinical examination. Search to find these 4 clinical signs and symptoms. What are the indications to do laboratory and neuroimaging? To categorize the indication, think for secondary Parkinson. Patient younger age, not a classical idiopathic Parkinson. Patient with acute presentation. Patient maintain with unilaterality. When we examined the patient, we found other neurological signs like pyramidal, cerebellar, sensory. That is means the patient is atypical Parkinson plus. We need for investigation. Neuroimaging for the brain, MR is sensitive to detect the basal ganglia pathology. Sometimes investigate for Wilson, for intoxication, and so on. In Parkinson's disease, how to treat? We put a guideline for treatment. First, treatment is symptomatic, not curative, because it is a neurodegenerative. With the time, the condition will progress. Second, treatment for life. Treatment divided into symptomatic treatment and surgical treatment. Try to think, what are the line of treatment? Look at this figure. The dopamine is formed in the, sensitized in the basal ganglia and stored in the dopaminergic vesicles. With the impulse, the dopamine will released in the synaptic cleft and act on the postsynaptic receptors. In patients with Parkinsonism, the dopamine receptors is degenerated, the amount of dopamine released is diminished. On the contralateral side, the acetylcholine is relatively increased. What are the line of treatment? First, may give a replacement therapy. There is deficiency of dopamine. The first line, the replacement therapy. The second line, stimulate the dopamine receptor to sensitize more dopamine. The third line, in the cleft there is enzyme called monoamino oxidase. When the dopamine acts on the postsynaptic receptor, the monoamino oxidase will break down the dopamine. So we can give monoamino oxidase inhibitor to delay the breakdown of the dopamine and increase its action. On the contralateral side, we may give anticholinergic to suppress the acetylcholine. This is the goal for treatment. Try to restore the balance between dopamine and acetylcholine by levodopa instead of dopamine. We'll discuss it. Why levodopa, not dopamine? Dopamine receptor agonist, monoamino oxidase inhibitor, catecholamine omesyltransferase inhibitors, anticholinergic and antiviral. First, replacement therapy, levodopa. Why levodopa, not dopamine? Because dopamine unable to cross the blood-brain barrier. When give dopamine oral, can't pass the blood-brain barrier, useless. So we give one of its precursor, levodopa, which can cross, and when we reach to the target location, we found the enzyme called the dopa decarboxylase will change it into dopamine to do its action. The dopa decarboxylase enzyme is present in the peripheral circulation, so it may convert the levodopa before it reaches to the brain. So that we give a combination of levodopa and the carbidopa. Levodopa is a precursor of dopamine, carbidopa to block the peripheral decarboxylation of the levodopa. The second, dopamine agonist, directly stimulates the dopamine receptor to sensitize more dopamine. The half-life of levodopa is longer than dopamine, but less potent, less effective. We give either a monotherapy in early stage Parkinson's disease or later on as an add-on with levodopa to enhance its action and to delay a motor fluctuation. Third, monoamino oxidase inhibitor, block the monoamino oxidase enzyme to help dopamine to accumulate at the postsynaptic receptor for a longer time and to enhance its action. Also, it gives in early Parkinson or add-on with levodopa. Anticholinergic, to decrease the acetylcholine, to try to make a balance between dopamine and acetylcholine. It's effective on the tremor, and it is a drug of choice in antipsychotic-induced Parkinson-like or drug-induced Parkinson-like. Antiviral. Why antiviral? There is no viral etiology. But when we find the mechanism of action of antiviral, we found it is weak anti-Parkinsonia, but it enhances the release of dopamine and inhibit its reuptake. So it enhances the senses and the release of dopamine. It may give antiviral to augment the action of the previously mentioned anti-Parkinsonia. Catecholamine O methyltransferase, it acts like carbidopa, delay the breakdown of levodopa, increase its half-life, but it should give in conjunction with a levodopa. Surgical treatment. In the past, we use thalamotomy or pallidectomy, destruction of the certain nucleus inside the thalamus, ventrolateral nucleus of the thalamus, or globus pallidus. The era now is what is called deep brain stimulation, try to control the hyperactive nucleus, or fetal negral cell transplantation. The second part in my lecture is hyperkinetic disorder. Hyperkinetic disorder, on the top, tremor, chorea, acidosis, dystonia, hemipalismus, tics, tardive dyskinesia. All this type of involuntary movement put under the category of hyperkinetic movement disorder. What is meant by tremors? We defined it before. Rhythmic regular movement at the joint level due to contraction of group of muscle and its antagonist. It is the most common type of involuntary movement. Tremor may be at rest, resting tremor. Tremor may be on maintaining a position like this, postural tremor. Tremor may be on performing action, action tremor, kinetic tremor, intention tremor, terminal tremor. This is a terminology or seminology for intention tremor. Resting tremor. The most common example is Parkinson's disease and secondary Parkinson and Parkinson plus syndrome. This is put under the category of resting tremor. We discussed it before. Postural tremor. Ask the patient out to stretch your arm. We found distal tremor like this. This is a postural tremor. It may be physiological tremor, patient younger age, 17 years, 19 years, younger and juvenile age, presented with very fine tremor, aggravated by stress. When we ask the patient out to stretch your arm, we found this tremor. Sometimes become visible to the other when introduced by other medication like alcohol, thyrotoxicosis, selective serotonin reuptake inhibitors. A patient with anxiety, we found this tremor is aggravated, called enhanced physiological tremor. And essential tremor. And this type of tremor put in the differential diagnosis of Parkinson, and we discuss it in the next slide. Kinetic tremor, intention tremor, dynamic tremor, or terminal tremor. This is one seminology for intention tremors. This action tremor. To observe this movement or this type of tremor, should perform a test. Ask the patient to do finger to nose test. Normal personnel should do the movement rapid, smooth, and target to target. But in patient with action tremor, the tremor appear at the end of the movement. Terminal or tension tremor. Also, we do finger to finger test. Ask the patient to do this movement, finger to finger. We found an intention or terminal tremor. The classical example of action or terminal tremor is cerebellar pathology. Benign essential tremor. This is the most cause of differential diagnosis to Parkinsonism. Tremor mainly at the arm, at the finger, maybe in the voice, vibrating tremor, or other part of the body. The tremor, not a resting tremor, it is a postural or action tremor. When we examine the patient, we found no rigidity, the tone is normal. No slowness of the movement, there is no bradykinesia, there is no flexed attitude, there is no masked face, and so on. The age is more or less younger than Parkinson, 40 to 50 years, and there is positive family history of disease in higher percentage, 50 to 70%. Investigation to exclude other causes of postural tremor, like blood examination, electrolyte panel, test for thyroid function, renal and hepatic. And because in some organ failure, like liver failure, renal failure, we found this type of postural tremor, aggressive tremor, flapping tremor. Treatment by beta blocker and topiramate. Topiramate is one of the anti-Parkinsonian It may be used in treatment of essential tremor in a small dosage. Examine postural tremor. This is older age female. When we asked to outstretch the arm, we found this tremor. And this is action tremor. Look at the jaw, look at the mouth, look at the hand. There is action tremor. When we examine this woman, we found normal tone, no bradykinesia, so it is not a Parkinson. It is essential tremor. How to differentiate between essential tremor and action tremor? Now we can differentiate. The next involuntary movement is chorea. Tremor is regular rhythmic movement. Chorea is completely irregular movement. Sudden, jerky, quite irregular movement as regard the site of the origin, the form of the movement, and the time interval. When we found the correct movement is the upper limb, the form, the examiner unable to expect the form. It may move the limb like this, or like this, or like this, unable to expect. The first movement starts in the upper limb. What is the next? In the other limb, in the lower limb, in the shoulder, in the head and neck, unable to expect the location. The time interval between two successive movements, unable to expect. So it is completely irregular as regard the form, the site, and the time interval. This is a child with correct movement, proximal in the upper limb, in the lower, in the head and the neck. Another female with correct movement. Jerky, quite irregular movement as regards the form, the site, and the time interval. The most common cause of chorea is Huntington chorea, degenerative, hereditary chorea. Second, it may be secondary to a list of the etiology, like secondary Parkinson, may be secondary to the autoimmune reaction, Sydenham chorea or rheumatic chorea. Female with infection by streptococcus infection, repeated tonsillitis. It may be secondary to drugs like antipsychotic. It may be secondary to Wilson. Post-kernicterus, child with hyperbilirubinemia, the bilirubin past blood-brain barrier precipitated in the basal ganglia and induce a pathology. May be due to natal hypoxia, cerebral palsy. It may be secondary to collagenic disorder like systemic lupus. What are the clinical features of the patient with chorea? Involuntary movement plus change in the tone. Involuntary movement, correct movement, we defined it before. Completely irregular movement in the extremities, in the face, in the trunk, occur at rest, and like any involuntary movement, increase during stress, disappear during sleep. What about tone? All extrapyramidal diseases, the tone is increased in the form of rigidity, except chorea. There is a hypotonia. Ask the patient to relax, do free movement around the joint to detect the tone. There is diminution of the normal tone, hypotonia. We found it around the elbow, around the wrist, and around the knee. We do certain tests or certain sign to detect the underlying hypotonia. Ask the patient to outstretch the arm. There is flexion wrist and hyperextension finger called boot shape or scaphoid shape hand. The second sign is pronator sign. Ask the patient to elevate and supinate the arm. Due to the presence of hypotonia, we found the limb is pronated and move downward. We stress on Huntington disease. It is one of the hereditary chorea. It is autosomal dominant due to defect in the huntingtin gene on the chromosome 4. The pathology is in the caudate nucleus, but the patient is presented with chorea and dementia. So, pathology in the caudate nucleus don't explain the presence of dementia. There is another lesion in the frontal lobe. What are the diagnostic signs? The age of presentation is around 35 to 45 years, middle age. There is gradual progressive chorea and hypotonia. Later on, gradual progressive dementia. and positive family history because the disease is autosomal dominant. When the patient fulfilling these 4 criteria, patient is Huntington chorea. This is female, choreic movement, sudden, jerky, quite irregular movement. We look, this is a demented patient. How to investigate? Clinical patient is diagnosed clinically. To prove the diagnosis, genetic study when there is availability of genetic lab, and imaging to the basal ganglia, we found atrophy of the caudate, which is responsible for chorea, and the atrophy of the frontal lobe cerebral cortex, which is responsible for dementia. To manage the patient by dopaminergic antagonist. The best common drug for dopaminergic antagonist in treatment of chorea is haloperidol, or tetrabenazine dopamine depleting agent for treatment of chorea. Look at this case scenario. Male patient, aged 45 years, middle age, gradual progressive dementia, involuntary movement, irregular in place and time, with positive family history of the disease. The age, middle age, choreic movement, dementia, and positive family history. So the patient fulfilling the criteria for diagnosis of Huntington disease. The next involuntary movement is hemipalesmus. Just define the hemipalesmus. This violent hemichorea, aggressive form of the hemichorea, affecting more the proximal joint, mostly due to lesion in the subthalamic nucleus. This is female presented with left hemipalesmic movement. It is aggressive form of the hemichorea. Myoclonus. Myoclonus means sudden shock-like muscle contraction, like this, shock-like muscle contraction. It may be single in one limb, may be segmental in more than part. It may be generalized. It may be epileptic or non-epileptic. It is stimulus sensitive, induced by loud sound, induced by unexplained movement, induced by high light. This is the myoclonic movement during sleep, sudden shock-like muscle contraction, sometimes physiological. The clinical type of myoclonus may be physiological, hypnic jerk during sleep, may be epileptic myoclonus or degenerative myoclonus. The next involuntary movement is dystonia. Dystonia, sustained repetitive muscle contraction, twisting in movement leading to abnormal fixed position. The best example to explain what is meant by dystonia, when there is sustained muscle contraction in the neck muscles, like this, we present with repetitive twisting movement around the long axis of the body. It may be focal, involving localized group of the muscle. It may be generalized. This is example of focal dystonia, what is called torticollis. The type of dystonia, generalized, involving the whole body, mostly hereditary in nature when it became generalized. It may be focal, according to the group of muscle affected. When we involve the neck, it is called spasmodic torticollis. When we involve the upper limb, it is called auricular cramp. When we involve the oromandibular muscle, called oromandibular dystonia, like this. We involve the eyelid muscle, we present with blepharospasm, like this. When we involve the vocal cord, spastic dysphonia. This example of the neck dystonia, torticollis. This example of the neck and the trunk and the limb dystonia. This example of the eyelid dystonia, blepharospasm, sustained repetitive muscle contraction. Dystonia occur in the long axis, along the movement along the long axis of the body. Acidosis is the opposite. a slow twisting movement in the distal extremities, like that, called mobile spasm. And mostly, it is associated with severe rigidity, severe increase in the tone, like this, dystonia in the limb dystonia, mainly distal, associated with severe rigidity. Next, tics, quick coordinated repetitive movement involving a selected group of muscle. It may be in the eye, like this. It may be in the neck, like this. It may be in the shoulder shrugging. It may be in the cleaning of throat. This is a repetitive movement. This is a tics. And the tics can stop for short duration voluntary by the patient. It is secondary to underlying psychic or stress factors. Blepharospasm, most elevation. Tardive dyskinesia. It is the type of involuntary movement induced by long-standing use of antipsychotic medication. Persistent, abnormal involuntary movement due to excessive exposure to antipsychotic drugs. Repetitive movement mainly involve the orolingobuccal muscle, called orolingobuccal dyskinesia, like showing movement, like this. All the time, it is irritating to the patient, poor response to the treatment. Choose the correct answer. Which of the following neurotransmitters is low in Parkinson's disease? Serotonin, gamma-aminobutyric acid, dopamine, norepinephrine. Try to think. Reason that dopamine itself is not used in the treatment of Parkinson's disease. Irregular, completely irregular, unpredictable, purposeless, involuntary movement, muscle contraction. This is the definition of acidosis, dystonia, tics, chorea, akinesia. Chorea occurs due to lesion in cerebellum, motor cortex, caudate nucleus, and subthalamus. Thank you.